Hi, this is Dr. Brower, and I'm going to show you how I do Botox in the masseters today to stop parafunction. So this is Dan, and Dan's agreed to let us video this, so what I want to show is kind of what we're doing. It's usually someone that's very brachiocephalic, and if you look here, the mandibular plane angle is quite shallow. Go ahead and bite together for me there, Dan, and relax. Nope. And bite together again. So you're going to see this little muscle jump here, and it's quite a bit bigger. We've been working on this for a while, and so we've been gradually bringing down the dosage of the Botox, but initially we did almost 50 units per side to start. So what I'm going to do is show you how I mark it so that we can get the entire head without getting up too high into the zygomaticus muscles, where we can actually cause some smile problems. So I'm going to go ahead and just grab the straight edge, and Dan, I'm going to have you turn away for me. And I'm going to go from basically the tragus to the corner of the mouth, and I'm going to make kind of a dotted line. You can make a solid line, but it's not very nice to the patients and harder to clean up. So then I take like a hard straight edge to find the mandibular plane angle, and I'm going to mark that as well. So those are my borders. If I stay within there, I'm not going to be too high, I'm not going to be too low, and I'm not going to have any side effects of the Botox that are unwanted. So then I like to take my finger back here by the ear and go ahead and close, and I'm going to feel nothing when I'm not on the masseter. Now as I move forward about 3 millimeters, go ahead and close. You can see my finger get pushed backward a little bit to the posterior. I'm going to move forward, go ahead and close, and there I'm right at the border. So I'm going to mark that.
Yep.
And I'm going to move down here. Go ahead and close. And I'm not there. Go ahead and close. There you go. My finger, go ahead and open and close again. And you can see the skin moves right there. And you go ahead and close. There you go. And I'm just going to kind of mark this right on this line. So that's the posterior border. Now I'm going to move my finger up to the anterior. And go ahead and close. And you can see it just pushed my finger quite far, so I'm going to move it more medial. Go ahead and close, and I'm not being pushed at all. Go ahead and close, and I'm finding the borders right there. Go ahead and close, and move backward, go ahead and close, and you can clearly see when your finger gets moved. And then go ahead and close, and it's quite strong. So it's a pretty big muscle. I've seen them half that size. And then, of course, the wider head is down here, and it comes up and attaches quite high. The temporalis is a secondary muscle, so go ahead and close for me, Dan. And what you're going to see is it's got a wide attachment here, narrowing down and attaching to the anterior portion of the mandibular condyle. Go ahead and bite together, and you can almost see it's like an oval right here. So sometimes you can go in, if this is larger, go ahead and bite. And it has a little bit of component right here. If you just want to give a little bit, sometimes that's helpful as well. So what I'm going to do is go ahead and mark the other side, and then I'll come back and we'll continue the video and I'll show you how I do the injections. Thank you. Okay, it's Dr. Brower and I'm back. So I'm going to show you a little bit with the diagnosis. From a dental perspective, what we want to look at is this area here on the panorex and this area here on the panorex. The temporalis, go ahead, it attaches here to the coronary process, and you're going to see that this is elongated and pointed in someone that has heavy parafunction. This antigonal notch right here will also be inverted instead of flat or everted, and you're going to actually see it even more so on this side because you can tell that he chews more on this side than he does on this side, which is fairly normal. So sometimes you'll actually see almost like a fang-like projection or multiple little bumps, and that the more of this that you see, the higher the parafunction. If this is more elongated, then you know it comes more from the temporalis. If this is more inverted, then you know it comes more from the masseter. And usually you have to treat mostly the masseter, secondarily the temporalis. So if you're having these patients do this by the unit and they have a limited amount that they can handle, then you want to spend most of that in the masseter and very little in the temporalis, and that's what we're going to do today. So what I'm going to show you is how I mark this. Go ahead and turn to your left. So I've marked both sides now, and I'm going to separate that masseter into sections and make a 6-pointed grid. So we know this is the majority of the muscle. As I go higher, there's less. And go ahead and turn to your right. And I'm going to do the same thing. The masseter on this side is actually smaller. We're going to go ahead and zoom in on that in a second, and I'll let you see how the masseter on this side is bigger than the one on the left. So I marked it, and that shows up as well on the x-ray. You can clearly see that that's bigger. So this particular 30 gauge needle is a 12 millimeter and it has a sliding hub. I like the sliding hub because it gives you protection. Normally we want to be anywhere from 5 to 10 millimeters in to get into the center of the masseter. So I just set that depth on my hub. And then I'm going to have you turn to your left for me. And I'm going to come straight down, right in the center, and deposit about 4 of my hashtags. And I'm just going to go straight in, marking that each time. Good job. And go ahead and turn to your right. If they have any discomfort, it helps them to just bite together. And go ahead and bite. And it creates a little bit of almost a transient paresthesia for them to put pressure on it. And I'm going to leave the top 2 because I really don't feel much there. And I'm going to use just a tiny little bit. Go ahead and turn to center. I've marked the temporalis here just with the front. And go ahead and bite. And you're going to see that this is quite firm. And I'm just going to put a couple of units right there. Very little. And I'm going to do the same thing on this side right over here. Go ahead and bite. That'll diffuse, upward to maybe the size of 10 millimeters from your center injection point, so that should get the heads forming. So that is how I do the masseters and the temporalis, and also some of the diagnosis that you're going to be looking for in the patients. You're going to see a lot of loss of posterior teeth, posterior root canals, a very flat monoplane occlusion, and you'll also see bone loss from heavy parafunction on implants. So this was before we were able to restore everything and get things settled down. So I hope that was helpful. Thank you.